Thank you for tuning in for this episode of Global Health Wavelengths, an interview series produced by the Jewish Healthcare Foundation dedicated to exploring innovations and best practice models from around the world to help inform and improve U.S. healthcare systems and policy. My name is Dr. Andrew Carlo, and today I will be your host for a conversation with Matthew Short and Dr. Ruth Vine about teen mental health in Australia. I am a physician and the Vice President of Health System Integration at Meadows Mental Health Policy Institute, and also a health system clinician at Northwestern University Feinberg School of Medicine. And I've been working to advance integrated care in primary care and pediatric settings for many years, both from clinical, research, and implementation perspectives. Today's guests are Matthew Short, Assistant Secretary, Mental Health Services Branch of the Department of Health and Aged Care in Australia, and Dr. Ruth Vine, Interim CEO of the Australian National Mental Health Commission. Welcome, Matthew and Ruth, to Global Health Wavelengths. Please take a moment and introduce yourselves.
Good morning from Australia. My name's Ruth Vine, as Andrew said. I'm a psychiatrist by background and have worked in both the public mental health system in Victoria in Australia and also at the Commonwealth in the role of Deputy Chief Medical Officer. And as Andrew said, I'm currently heading up the National Mental Health Commission. And young people's mental health has been a major issue for Australia for a number of years, but I'm sure, as we'll discuss shortly, remains a very critical issue for us. Thank you.
Thanks. Hi, everyone. Yeah. My name is Matt Short. So I am, as Andrew said, the Assistant Secretary for Mental Health Services in the Commonwealth Department of Health and Aged Care here in Australia. I am an administrator and a bureaucrat. We look at systems, mental health systems here. I have policy and program responsibility for youth mental health, sits within my remit within our Federal Department of Health and Aged Care. And we work closely with the Mental Health Commission and our states and territories who are part of our federated system of healthcare here in Australia to ensure that we can advance the needs of young people. So looking forward to talking to you today.
And thank you both again for being here, and I'm looking forward to getting started. So I wanted to kick us off by asking if you could both briefly give us some context as to where things are with the youth mental health crisis right now in Australia. Provide us just a little bit of context and background so that we can frame this discussion.
Yeah, thanks, Andrew. And I might start off. The first thing I'd say is we collect information in a number of ways, as I'm sure other countries do. But in particular, last year we had the release of a thing called the National Mental Health Survey. And this was the first time this had been done since 2007. And one of the standouts of that survey was that the prevalence of mental ill health in the 16 to 24-year-old group had risen dramatically from 26% in 2007 up to almost 40% in 2021. So, and that meant that the young people really had the highest prevalence of mental health disorders across all age groups, with 39%, nearly 40% experiencing a 12-month mental health disorder. And they also had the highest rates of thoughts of self-harm, actual self-harm, and suicidal ideation, as well as other problems such as eating disorders. So that was a standout change. And then, of course, we also noted that during the pandemic, during the COVID years, there was a further impact on employment, housing, education, social participation, and loneliness. And each of those also seemed to have, if you like, a greater impact on young people than on other age groups. So we've had a few other surveys. One of our major research institutes, the Black Dog Institute, released a report in October 22 titled Turning the Tide on Depression, which again showed increased rates of self-harm among young people, and particularly among our First Nations young people. And likewise, we also had a survey done by Mission Australia, which also showed that among the top three issues raised by young people were concerns about the environment, concerns about equity and discrimination, but also concerns about mental health. So I guess we've had all of those large-scale surveys, as well as issues like increased numbers of young people presenting to our emergency departments, and not just young people, but younger people. So higher rates of people even before their teens presenting with problems like eating disorders, suicidal ideation, and self-harm.
Clearly, all indications point to a worsening of this crisis immensely, particularly in recent years. Although I imagine it's not unlike the United States, where it has been a crisis for some time that's just been exacerbated of late. Is that your sense in Australia as well?
Look, I think it's true to say that pre-pandemic we were aware of this increased levels of distress in young people, but I do think the pandemic exacerbated it, and I do think we're doing a lot of work looking at perhaps the impact of digital technology, of increased screen time, and of that, if you like, that sort of increased global awareness of things going awry in the world, and I think this particularly impacts young people.
Absolutely. Matt, go ahead, please.
I just add two things to what Ruth has said, and that is with the National Mental Health Survey. One of the When we compare it to the general population across that time period from 2007 to last year, that the general population has remained relatively stable, whereas the youth population has declined. So that is very was very telling for us. And I think the other thing I'd point out is it's worse for young women. So what that survey showed for us is that rates of mental ill health are much worse. It's half. 50% of young women have had a diagnosable mental illness in the last 12 months, which was new news to us, and something that we'd seen coming through hospital data. But yeah, we've now got this national prevalence data that confirms what we had heard.
I wanted to shift a little bit toward what is being done to address the crisis. So first, like what programs have been implemented, what policy changes have been considered or actually implemented, and then how are some of these disparities being mitigated that you mentioned, especially for the First Nations peoples, and then also, I guess the second part to that question is how are we addressing high risk groups, specifically, Matt, to your point, perhaps young women would be one of those groups. So what are we doing to address the crisis broadly, and how are we targeting high risk groups, and how are we mitigating disparities?
Yeah, thanks, Andrew. So I think in Australia, one thing I'd point out so a bit of context before I go into what we're doing is that we work in a federated system. So states and territories, there are 8 of them across the country. They are responsible for healthcare in Australia, whereas the Commonwealth provides funding, policy support, but we don't run hospitals, for instance. So our hospitals are run at the state and territory level, but we work closely with them on policy levers that the Commonwealth has at its control. So I think that's just one thing, and I'll get into why that's really important for us in mental health, and particularly in youth mental health. But I will give context. So Headspace, we're here. Headspace is our national program that the Commonwealth funds to support young people, and that is age 12 to 25-year-olds. So Headspace is the government's flagship program for youth mental health. It's been around since 2006. So it's interestingly been around for the time period we've had of the last prevalence data. And it's really grown as a network. It started out as an idea, and there was 30 services funded across the country. It's now there's 154 services operationalized across the country, with 170 to be opened over the next few years. Now it is multidisciplinary team-based care in community settings outside of hospitals, and it is a free service for young people, a walk-in service, and it provides 4 straight core streams of support for young people, so that to look after their physical health, mental health, sexual health, vocational support, sexual health and AOD support, and vocational support. So it is a holistic look at the young person. It's not just a mental health service. And I guess what the government has done recently to invest, so we've evaluated the program 3 times over the course of the last 15 years. But the last evaluation was last year. So we're still looking at the findings of that evaluation that was released in October, and working on the improvements needed. And that shows that actually the model, and we'll get into the evaluation a bit later, but I think it shows it is an effective model of care, but that more is needed. And we know that from the data, that more is needed to support young people's mental health. So the government is investing more funding into Headspace services, and what we're calling it, we're enhancing the services. So that is to lift the base level of funding so that they can attract and retain more workforce. And I think that's like the need is there, and I think the ability of the workforce to meet that need is one of the key things we've recognised. What has happened in the last 15 years as well is that the young people presenting to Headspace are more severe and complex than what the model was designed for. So the model was originally designed for young people presenting with mild to moderate mental health needs, and we are seeing that becoming more and more complex. So we're looking at how we work with states and territories who generally are responsible for young people who are at that more severe end, and that is through what we negotiated with states and territories a new national agreement on mental health and suicide prevention, and that is with all states and territories, and a commitment across all governments to focus on a range of issues, and youth mental health is one of them, and it's in every agreement with the states and territories, and really looking at that integration with clinical, severe, acute services run by the states and the Headspace services that we run out in communities that the Commonwealth funds, and looking at and we've got co-investment for the first time in a long time, first time ever, I should say, from the states and territories to look at the clinical models across that severe end of the spectrum and what we are funding in the community.
Yeah, I wanted to follow up by asking, because I had the fortune of visiting a Headspace location in the Northern Territory in Darwin. And I learned when I was there that Darwin was one of I believe that there's a smaller number of the Headspace locations that do offer psychiatric services for more acute and severe mental health problems than most of the locations. Can you say a little bit more, Ruth, about how many of these new locations are going to have those types of services, so psychiatric services or services for serious mental illness?
So this is it is a difficult question because, as Matt said, we're in the process of enhancing the headspace. That's more likely to enable us to employ more, more psychology staff than necessarily bring in psychiatry. In Australia, there's also quite a complicated funding model. So our Medicare benefit schedule is a fee-for-service model, and quite often attracting psychiatrists through that funding model can be difficult if it's to be kept a free service. So often psychiatrists will add a fee onto the base service. What's most important about that addition of psychiatry really is getting the integration between state and territory services who do employ psychiatric staff and the headspace services that sometimes employ psychiatrists but more often will have general practitioners or psychologists. I think the other thing that I'd add to what Matt said about the headspace services is I think our growing recognition that we also need to get into younger people to improve outcomes as people grow older. So Headspace mostly sees people aged 15 to 20, 23, 24. It can see people from age 12 and up, but we really also now focusing on thinking about services for the under 12s. And I do just want to throw that in because one of the things we're seeing with our young people's mental health is a growing concern about the very young as well as the adolescents. And I do think also that workforce is a critical one. So even when we think we might be able to employ a psychiatrist, it might be very hard to find one, particularly in rural and regional areas. And the same applies really to experienced psychology staff, so clinical psychologists and those who can best assist with those who are presenting with more complex presentations, particularly when there's drug and alcohol as well as levels of psychological distress or where there's emerging really significant psychiatric illnesses.
Absolutely. So that's great.
And sorry, Andrew, just to add to that, Ruth's made a very good point, and maybe a good time to spruik Ruth, the Australia's world first national children's mental health and wellbeing strategy. So that is a strategy that the Mental Health Commission produced and worked with states and territories and the Commonwealth on, and has been was released at the end of 2021 and has a number of key actions for governments to undertake, and was the first of its kind in the world, which we're very proud of.
Yeah, it's a good strategy.
Yeah, thank you for elaborating on that as well, and as well as calling out that very high risk, early adolescence or maybe even late child or middle child group of patients who often have emerging mental health problems that are not addressed. I wanted to follow up by maybe starting with you, Ruth, for this one. What is being done specifically to, and this may be part of what you were already saying, but what is being done specifically to target at-risk youth for services in a preventive way? And then also what is being done to mitigate disparities for the First Nations peoples and other groups that are traditionally underserved in Australia?
Sure. Look, but maybe to start with that question, again, in Australia, we do have First Nations led, First Nations sort of governed health services. So I think one of the things to highlight is having services that we would say are culturally safe and that emphasise both the social and mental health and well-being, that sort of more cultural context than traditional clinical services. So I think we are very aware that we need to look at both the staffing model, but also, if you like, the underlying cultural approaches, and we're certainly focusing on that. I think there is a real issue around how to target particularly disadvantaged youth or how to target particular areas. And one of the great things about the Headspace model is its geographic spread. So the fact that it does have centres in rural and regional, I think we're getting better at having a capacity to do a bit of outreach, because while Matt said Headspace centres are there for people to walk in, sometimes you need to actually be a bit more assertive in hard to reach groups, and that does mean being able to provide some outreach to schools. When we've had disasters like the bushfires that Matt mentioned before we started, that that need to sort of bring in additional services and additional availability, I think we're becoming more agile in how to do that. And in fact, I think we learnt during COVID, during the pandemic, that need for agility and the need to supplement services in particular areas to improve accessibility. And probably the last thing I'd mention is, again, one of the problems with the service is if there is increased demand, you can end up with wait lists. And a wait list is no good if you're in extreme psychological distress or if you're experiencing a crisis. And so, again, the other thing that we're doing is sort of building the front end, if you like, to be able to respond via phone or on the on digital apps to whatever, to get a more rapid response and a more wraparound service. But I'm sure Matt might like to add to that.
Yes, please.
Yeah, thanks, Ruth. Yeah, on the First Nations front, I think, and in other vulnerable populations, our evaluation last year did show that Headspace needs to do more and better to reach those hard to reach groups. And Headspace, so we fund. I think another thing to mention is that Headspace, there's an organization called Headspace National, and they provide policy advice and a sort of a peak agency for our Headspace services, and the Commonwealth funds them to run national Headspace programs as well. Whereas we fund the funding for the actual Headspace service we do through our it's called a primary health network. So something to be aware of is that Headspace National has been running a cultural capability program to uplift, I think, the ability of Headspace services and clinicians to be culturally safe, as Ruth said, and to provide culturally safe services. So it's been a really big focus and is a big focus for us at the moment. There are a few innovative models of care that are being trialled to support this, and one in the west of New South Wales at the moment, which is stepping out. And that is about what Ruth mentioned, outreach. So making sure, so we're training a new model of care where it isn't as place-based, where people come to you, it's where you go to them. And that is training Aboriginal health workers in 10 small communities to go out there to meet community, to talk to young people where they are. So there are a few models being trialled. We've also got in the Headspace network more broadly, the Headspace services are run by what we call a lead agency, and there are a number of those that are run by Aboriginal community-controlled organisations. And I think we're seeing those models be really effective for First Nations communities, and looking at what we can do to support that across the network. The other vulnerable population group, the evaluation found that LGBTQIA plus young people need more support. And as we've mentioned, actually, so whilst young women have the highest prevalence, they actually also have the highest help-seeking behaviour. And in fact, our Headspace, they're about 67% of presentation. So we are actually looking as well at how we can get young men to attend and to seek help. So I think that's another group that we're looking at.
Thank you both so much for expanding upon that. I think it's wonderful to hear what's going on, particularly for the underserved populations and the at-risk populations. I want to shift a little bit. You both mentioned workforce. I want to ask you both, and perhaps Matt, we could start with you with this one. What is being done specifically to improve the pipeline for the workforce, and also to train people properly to deal with these acute high risk populations with mental health comorbidities.
I might kick off again, Matt, if that's okay.
Please.
So, firstly, absolutely a recognition that workforce is often the main barrier to setting up a service. We might have funding, we might have a location, and we struggle to get both the right mix of workforce and the right seniority of workforce. So, a couple of things to say. I mean, clearly, we are trying to improve the pipeline. That's through increased numbers of training positions, particularly for psychology, scholarships for mental health nurses, increased rotations and expanded rotations, both for psychology graduates and also psychiatry trainees. So trying to establish training positions within headspace centres, within the private sector, and within new models of care. We do have to work really closely with the states and territories because most of the training ground, particularly for medical graduates and psychology and social work and allied health, are within the state and territory funded hospital system. But it's also, so there's more of each of those streams, which is a constant effort. But I think we're also trying really hard to think, how can we broaden the scopes of practice and how can we broaden the role? And perhaps one of the most important emerging workforces in this area is the lived experience workforce. So people who can provide peer support, who can provide some of those sort of service navigation and coaching roles, concierge type roles to welcome people into services and help them navigate their way through. So introducing new streams, trying to broaden the streams of others. So we do have a growing nurse practitioner model, which allows nurses to undertake limited prescribing, but more thorough assessments. And probably the last thing I'd mention around that is also trying to improve the interest and competence of general practitioners, so people who work in primary care, through additional training and exposure to training and experience in looking after people with complex mental health presentations. So that's not just about young people. I mean, we're clearly also trying to focus on developing more child and adolescent psychiatrists, more psychologists who have confidence in this area, better use of counsellors. But really, it's all of the different streams of workforce, and as I said, very much in conjunction with our state and territory colleagues.
Thank you, Ruth. Now, would you like to elaborate as well?
Yeah, and I think I'd like two things I'd say. One is just as Ruth said, working with states and territories is really important for us when we're talking about workforce. And so under the national agreement, which I mentioned earlier, there is an agreement to a 10-year national mental health workforce strategy. And so that is working closely with states and territories to look at options to attract, retain, train, maximise and support the mental health workforce. So I think it's a work in progress, that's for sure, but there's lots happening in that space. I think in the headspace model, recruitment of staff and retention is an issue, particularly working in headspace services are quite small services in a community, and when you compare them to the state funded local hospital network, they are very small. And so it's looking at the salary models. What can we do to support clinicians working in what we call in primary care, outside of the hospital networks? Because we know if we can get to young people or people in community and keep them out of hospital, they stay better. So all their health outcomes are better. There's a couple of programs specifically for headspace workforce that we've funded recently that I'd point out. One is what we call the Headspace Early Career Program, and that is, in line with what Ruth mentioned, a program where we are looking to provide workforce students and graduates clinical placements in headspace centres, so they can train there. Because we know if we can train them in those settings, they might be more willing to stay and provide services after they've graduated or are ready to. And that is only implemented last year. We've just had our first 50 students and 50 graduates provide their first 12 months. So we're in the early days of that program and looking at evaluating it and seeing if it's working. But anecdotally to date, yes, it's going quite well. But yeah, a long way to go.
Thank you both so much. We only have a few minutes left here. I wanted to maybe wrap up by talking a little bit more about evaluation. You both mentioned it before earlier. We talked a little bit about the evaluation of the Headspace model. Can you say a little bit more about how evaluation is done broadly, both at the Commonwealth and state territory levels, for the youth mental health initiatives at large? That could include Headspace, but also the efforts at large.
Yeah, there are, Ruth, if you're okay, I'll jump in. There are a few ways we do it, and some is at the program level. So as I mentioned, the headspace evaluation specifically, but then I think there are other broader ways that we're looking at the system, um, both with the states and territories and with other providers. And interestingly, actually, the government, so the Albanese government, which was elected last year, is putting in place a new model of engaging with young people, so to make sure young people's voices are heard and can input into policy decisions and design. And I guess it's like not an evaluation per se, but it's just a new way of doing things. And so there is a new youth engagement strategy. And so as part of that, they've set up youth advisory groups, and there is a youth advisory. There's 5, and one of those is on mental health and suicide prevention. So we are co-leading that with the Mental Health Commission, where we get to talk to 8 young people every month about what is happening to them and in their lives and in the system to inform policy. And I think that is a really innovative new way of the government doing things. We do, of course, talk to young people through policy design, but usually through headspace services. So this is looking at it more holistic, which has been really useful. But we do, as I said, program evaluations. We are looking. There are a number of we've talked about Headspace, but there are a number of youth services that we are funding outside of that. And one of those is at the more severe end that we fund through Origin, our Centre for Youth Mental Health, and it's called the EPIS service, the Early Psychosis Youth Severe Service. And looking at evaluating that model and how it operates in headspaces as well, but only in certain headspaces. So looking at that as an evaluation piece. And then I think more broadly under the national agreement, a real commitment from all governments to evaluate the system as we go, and to look at the models of care. And then my final point is that in 2020 we had a productivity commission inquiry report into mental health, and that has really been a driver of reform for us for the last sort of 3 years, because that looked at the whole mental health system, conducted community consultations, and really did a thorough examination of what is needed, and it's still driving reforms for us today, and will do so for the future.
The only thing I'd add to what Matt said is we're much better at the moment. We're much better at evaluating how much services are used. So if you like, inputs, number of people who receive a service, hours opened, all the sorts of measurements like that. We struggle, I think, to measure outcomes as opposed to inputs and outputs. So some of the focus I think that we're trying to develop is to get better at what is actually both the short and the longer term outcome. We can do some of that through surveys. We can do some of that through qualitative responses, people's experience of service, but we really don't do it well. And I think as we continue to focus on evaluation, value for money, effectiveness, and appropriateness, that we do need to find better ways of measuring outcomes.
Yeah, we have the same challenges in our systems, particularly with youth, because we're not just measuring symptoms. Of course, we want to measure functional status and school performance.
That's right. We want to measure educational engagement, employment, family function, family cohesion. All those sorts of things are really important in terms of outcomes for young people's mental health.
Absolutely. So I wanted to ask a little bit more about digital health techniques. You both alluded to them briefly at various points in this talk so far. I wanted to know what's being done at either the Commonwealth level or the state territory level to leverage technology to reach populations or to just enhance care broadly.
Yeah, lots is being done. I think we'd say, Ruth, that and one of the very few benefits of COVID was showing us the importance of digital technologies in being able to access people where they are and in place. And so broadly across the mental health system now, telehealth is fairly common and is funded by the Commonwealth for a number of its programs, but particularly the Better Access program, which is our large program that anyone can access for Medicare subsidised psychological services. But in the youth space, I think one thing I'd mention is Headspace has recognised that early on and implemented a program called Headspace. And so that is a program that's been around for a number of years now, and it acts young people who are accessing Headspace services, or as Ruth mentioned earlier, on a wait list for Headspace services, because that is an issue, are able to access moderated online therapy and support whilst they're where they are. And so last year, we don't have the data for 22-23, but for the year before, it was about 55,000 occasions of service were accessed through eHeadspace. So we think it's a great program. Of course, we know young people. One thing we do know for young people as well is a lot of they might come for one service but not come back. And so looking at why that is and whether digital technologies is a way to enhance their engagement with a mental health service is something that we are looking at. We also fund outside of Headspace a social media platform called Our Herd, and that is a moderated online social media platform where young people can share mental health stories about their own mental health journeys. It's a destigmatization tool. It's proving really popular and something that the Commonwealth is very excited about as well.
So are the youths and their families or their families responsible for any of the costs associated with these services, both in person or virtual?
They are free services. Yeah, no costs. Yeah, fully funded by the government. Yeah. And one thing I'd note is families can also access those services. So eHeadspace is available to families as well.
I'd add two things. I mean, there's a wealth of models of care out there using digital technology, and in fact, sometimes the problem is which is the right one, and how should people be navigated towards those. And so I think we also have a job to educate our primary practitioners, our general practitioners, to help them provide information and advice on which of those platforms might be useful. And the other side of the coin, I think, is and certainly the commission where I'm working at the moment is doing work in this, is what are the dangers of screen time, and what is the downside of some of the social media platforms that people access. So we certainly know that we should be harnessing it for good, but I think we're also exploring and struggling to work out how much it should be limited and how we can get people engaging with each other and with outdoor activities and exercise and all the other things that don't involve screen time. So that's the other part of it. And thank you very much.
Yeah, that is definitely an issue that we're trying to grapple with here, that we are grappling with, I should say, in the U.S. as well. So with that, I would thank you both, Ruth and Matthew, for joining us today for this episode of Global Health Wavelengths. It's been great to have you both, and I've learned a lot. Do you have any final thoughts or comments before we wrap up?
No, thank you very much for involving me.
Just to say thank you. We've got lots to learn from each other, and we're very happy to have had this dialogue and continue to see what's happening across the world as well.
Absolutely.